hope that you all get something out of it as well. So just some brief introductions. I'm a postdoctoral fellow at the National Center for PTSD here as part of the VA Palo Alto healthcare system. And so my research here is working on improving the assessment and treatment of sleep disturbances among trauma-exposed veterans. So this is a topic that's really close to home in what I'm doing. And clinically, I also provide cognitive behavioral therapy for insomnia. Last year, working in the primary care setting, and now here working in the residential treatment program. So, something also that I'm very familiar with on the clinical side. And Dr. Jameson is a clinical psychologist as well at the National Center for PTSD. And so she'll be helping me along with this presentation, chiming in, as well as helping to navigate some of those questions that you have. So like Afiq mentioned, if there's questions particularly with clarifications as we go, we would really like you to put those down in the Q&A or chat so that we can make sure we address those as we go. So before we get started, of course, no financial or personal disclosures at this time, especially in my early stage of career. And the views that we express today are our own, not necessarily representative of the government. So this is a very broad topic area, and so we've tried to hone in on four main points. So the first thing we're going to be talking about are what are those sleep disturbances that are common following trauma exposure? Why is there a link between trauma exposure and sleep disturbances? And then we'll switch gears and focus more clinically on ways to assess these, bringing these things up in clinic, and then what are some of the interventions that are out there for treating these conditions? All right, so the first area that we're going to be focusing on are the sleep problems after trauma. So some of those common things that people may be presenting with. So I'm probably speaking to an audience that's very familiar with the PTSD diagnostic criteria from DSM-5. But I wanted to highlight here, these are the different symptom categories and the clusters. Highlighted in this burnt orange or reddish color are the sleep disturbances that show up in the diagnostic criteria. And so we can see the distressing dreams or nightmares showing up in the re-experiencing or intrusion cluster. And then we're seeing the difficulty falling or staying asleep or the insomnia symptoms in that arousal cluster. And what this really highlights to me is the high likelihood that individuals with this disorder will present with sleep problems. We're seeing these things show up in multiple categories. And while nightmares and insomnia are part of the diagnostic criteria, it's important to note that these symptoms may occur outside of a formal diagnosis. So for example, an individual with nightmares may not meet full criteria for the disorder. And indeed, like what we'll talk about later in this conversation, is that insomnia in particular often sticks around long after, even if people have been successfully treated with prolonged exposure or cognitive processing therapy, for example. So the first area that we're going to talk about are those distressing dreams or nightmares. So some of the types of problematic dream occurrences that can show up, what I like to think about is how these are on a continuum of subjective distress. And the main point of this slide here is really to make sure that we're all on the same page of some of the definitions. But as I'll note, frequently throughout this presentation, there's a lot of debate in this field and discrepancies between how people define things, and I'll point those out as we go. But starting on the lower end, and we'll move up with our fun graphic here, is on the lower end. I don't know if you all can see my arrow when I'm pointing.
Oh, now is there a way to make it a pointer?
No. Okay, so I'm in the green.
Actually, there's a pointer.
There's a pointer. Oh.
Okay, I'll just move it.
Oh,
Okay, well, on the low end, this on the night terrors, so the green green circle here, I like to think of this as at the lower end of subjective distress. So although it has a horrible name, it sounds pretty terrifying. The individual who experiences these likely doesn't recall them or remember them in the morning. So a night terror is characterized by an individual maybe sitting up, screaming, eyes are open, but they're not awake, and they're actually very difficult to arouse out of this state. So these occur often in children primarily, and so it's super distressing for parents who have to deal with their child screaming out. But often the individual in the morning doesn't recall that. Moving up, so we have the blue circle, the anxiety dreams. These are the distressing dreams that people may have throughout their lives. I like to call them bad dreams, top content that may not be so good. But generally, people sleep through these. They may remember them in the morning. Oh, I had a bad dream, or that was unpleasant, um, but they aren't waking from them. And that's where I want to distinguish the nightmare component. And this is one of those areas that's highly debated in the field. So right now, a universal, I'll say it with a caveat, but a pretty universal characteristic of a nightmare is that they wake the individual up from sleep. So the individual may wake up, recall the content of that dream, may be sweating, have a heart racing, and so forth. But the distinguishing factor between the top two are that the REM nightmares, or what we call idiopathic, maybe lifelong nightmares, generally occur during REM sleep. They're usually in closer to the morning time, not having too much movement, but again, sort of having that unpleasant dream content. And there's different reasons for why people have these. So some people have them when they have fevers or illnesses. Some people are more likely to have them. Some theories are from personality characteristics or people who are more creative, for example. But generally, these are things, every one of us probably have had a nightmare once or twice in our lives or more. The top area, which is what we're going to be focusing on during the presentation, are trauma nightmares. So these could be in the literature called trauma nightmares, trauma-related nightmares, post-traumatic stress disorder nightmares, all sorts of things. But these generally occur following a traumatic event, or if the individual was having nightmares before the trauma, they may be exacerbated. So maybe their nightmares are increasing in frequency or severity, the content may have changed. What's distinguishing from the REM nightmares here is that some of these nightmares also occur outside of REM sleep. So in stage 2 sleep, they also might occur earlier in the night. And this is particularly distressing because if people are not able to fall back asleep, they may be losing out of large chunks of their night in their sleep in their nighttime. So on to the next slide. Oh, so I want to just mention again on this continuum of distress, these are at the higher end because if individuals are reminded of their traumatic event, they are waking up potentially in a panic, and then now they might be ruminating about that trauma. This may lead to more daytime distress and then the likelihood of having more nightmares. So on to the next slide here, just so we kind of hone in on that definition. So nightmares, for the purposes of our conversation tonight, are repetitive or distressing dreams that cause that awakening, and the individual is able to remember or recall that content. Let's look at the prevalence here. So in the general population, so these idiopathic or REM nightmares are occurring at about a 1 to 8% of the population. But as you can see, those rates jump quite considerably when we throw on trauma exposure. But as what you'll notice here is that it's quite a range. 19 to 96% is very varied. And the reason here is that there's not a good consensus on the definition. Like I said, there's debate. Some people don't believe that the waking criteria should be included because people are not so good at remembering if they woke up or not. We don't have the best methods for determining if a nightmare occurred. We often just ask people, did you have nightmares last week? And so there's not a very specific way of assessment. And we'll throw on this splatter here is that they're very hard to study. And so Dr. Jameson and I work with Dr. Stephen Woodward at the National Center. And part of Dr. Woodward's sort of his career has focused on better ways of assessing for nightmares. He does a lot of other things as well. But part of some of his thoughts have been, well, the nightmares don't show up in laboratory settings, for one, very frequently. And some speculation is that individuals may feel safer when they're in a lab because there's a technician there, they're being monitored. Additionally, nightmares are pretty a conditioned experience. So when you have them repeatedly in your home bedroom and then you're outside of that area, you might sleep better. And so we've had anecdotally people like sleeping in hotels who have nightmares because they actually have fewer nightmares, where a lot of folks who don't have nightmares may say they sleep worse in hotels. But either way, we see higher rates of these trauma nightmares in our veteran and active duty populations. And I wanted to touch base just briefly on the content of the nightmares, particularly with our military populations. So there's again, different definitions here, but generally the content falls within three areas. So replicative, or basically replays of the traumatic event. We have similar content to the traumatic event, and then dissimilar or seemingly unrelated. And the closer the nightmare content is to a real life event, the more associated with greater distress, greater PTSD diagnosis. And what we see among our military and veteran populations is that they're more likely to have nightmares that are these exact replays of traumatic events. And so may be linked to greater distress as well. So that's one area of the PTSD criteria. The next are the insomnia symptoms, or the difficulty falling or staying asleep. I really like this image. I chose this purposely because I think this really reflects a lot of the veterans or service members that I see in clinic, where they are tired, their bodies are exhausted, but their mind is wired at night. So they crawl into bed and then they're starting to think about everything, thinking about their traumatic events or planning or what happened during the day. Did I have a fight with someone? And so they spend great deals of time laying in bed, tossing and turning, maybe being really frustrated as well. And so what I wanted to also point out here is the prevalence rates. In the general population, particularly with veterans, we already see a large rate of insomnia among our veterans, even before we consider trauma exposure. And we'll talk a little bit about why this might be related to just their military service, but that's already giving us an indicator that people may be coming in with sleep problems. And then when we throw on the trauma exposure, you can see those large numbers popping up, particularly among our military groups. And so I consider insomnia one of those sticky symptoms or pernicious symptoms. It hangs around for a long time, decades. And again, like I mentioned, even after a successful PTSD treatment, we see this symptom hang out. All right, so those are the main symptoms that pop up with the criteria. I wanted to direct briefly about objective sleep parameters, so what we see when folks sleep in lab. And there's some discrepancy between how people subjectively rate their sleep and then what objective reports are showing. And so among our veteran population, we see some studies showing that folks with PTSD tend to underestimate how much time they're getting, and they overestimate how long it's taking them to fall asleep. And this may be related to that PTSD diagnosis because they're of more pre-sleep activity. So being more aroused at nighttime, maybe having that anticipatory anxiety about going to bed and having a bad night of sleep. Um, Folks with PTSD also have been shown to have more arousals during the nighttime, and so that may lead them to perceive that that time awake was much longer than it actually was. But interestingly, another study found that individuals with PTSD were actually more accurate about their sleep disruption than non-PTSD groups because they're more vigilant about monitoring their sleep. So there's some debate about this as well. But in general, sort of with meta-analyses or review papers on polysomnography, or the gold standard way of measuring sleep objectively, folks with PTSD tend to have less deep sleep, more disruptions to their REM sleep in particular. I also wanted to highlight sleep breathing disorders, or particularly obstructive sleep apnea. So while insomnia and nightmares are part of the diagnostic criteria for PTSD, this is one of those symptoms that is gaining a lot of attention, as it should. So the most common diagnosis is obstructive sleep apnea, or OSA, which is characterized by repeated upper airway obstruction during sleep that leads to arousals and sleep fragmentation. So generally, people might say they're loud snorers, or their bed partner might say that they gasp at nighttime, and that may be a sign of sleep apnea on board. And as you can see from the military population prevalence statistic, that this is gaining quite considerably in terms of prevalence among, especially within the VA system, where they're starting to evaluate this more frequently. But it can have serious consequences, particularly with PTSD or depression symptoms. It can interfere with PTSD treatment progress, and it has serious health consequences. So it's linked to cardiovascular risks, diabetes, as you can see, may potentially cognitive impact, especially in our older adults, and then also accidents, so motor vehicle or difficulties at work as well. And so if sleep apnea is on board, it can really be difficult to treat other sleep problems. While not impossible, it may not be able to improve everything. But as we'll talk about in the treatment section, trying to get folks to wear a CPAP is really challenging. So Dr. Jameson and I work with folks in the PTSD residential treatment program, and it's hard to we can count, countless folks who they've been diagnosed with sleep apnea. We ask them, oh, did you bring your CPAP to the program? No. Do you ever wear it? No. I tried it 5 years ago, I hated it, and that was that. And so it's something that is challenging to get folks to use, but important. Another sleep problem that may arise following trauma exposure or show up in greater rates is REM behavior disorder, or RBD. And so this is characterized by basically acting out during REM sleep. So rather than having that muscle being paralyzed, they may be acting out, particularly like dreams. So this image here is, for them, it may not be so bothersome, but if they're sharing a bed with a partner, it may lead to some issues. And individuals with PTSD are diagnosed, are 10 times more likely to report these larger body movements. However, it's unclear whether or not those are specific to REM sleep or not. And more recently, a group that I cannot pronounce their name, I tried to when I was practicing the M last name here that I have, but they are part of the DoD, and so they've come up with this term, trauma-associated sleep disorder. And so this is gaining more attention, that potentially the sleep disorder associated with trauma may be its own clinical entity. And so they're looking at using case studies and trying to expand that, looking at acting out of these trauma-related nightmare scenarios that they're seeing showing up on objective measures. So that's something that is more recently being looked at, and I'm sure will continue to be expanded upon. Okay. So in the past, when we thought about sleep problems after trauma exposure, sleep problems have really been considered a secondary issue. So if we treat PTSD, everything else will go away. And that thought has started to shift a little bit. So rather than sleep problems being something that we deal with later, they may be conceptualized now as a primary concern. And the reason is that studies are suggesting that sleep problems prior to trauma may increase our risk of PTSD. Sleep problems in the immediate aftermath of trauma may increase risk of PTSD. And treating PTSD doesn't always affect sleep problems, but what we see is that when we start tackling nightmares or insomnia, we can start alleviating some of those other PTSD symptoms. So it starts to bring to our forefront that maybe we should be looking at sleep problems as a primary issue. So we've already sort of emphasized why we should care, and I'm probably talking to folks who understand what it's like when you don't get good sleep, that it's important that we can feel the consequences pretty immediately. But particularly among our military and trauma, or military and active duty folk, we want to really think about how do sleep problems impact other areas of their life. So if you work with veterans or military personnel, you might know that they can be challenging cases at times. They often do not come with only sleep problems or only PTSD, but they may be showing up with other mental health concerns, difficulty with their weight, cognitive issues, other medical complexities. And so what we know is that if individuals are not getting adequate sleep, many of these other problems can be challenging to treat. So there's the health implications. Suicidality and suicide is, of course, a concern when we're working with this population. And sleep complaints, particularly, have been linked to greater suicidality and even suicide attempts. And so the group up in the upper state New York, the Pigeon Group, I can't remember the exact name, but they're the Center for Suicide, basically prevention. They found that sleep disturbances, so even subjective rates, led to these large relative risks for acting on their suicidal thoughts. And this was even beyond depression and PTSD symptoms. So we're seeing that insomnia and nightmares are a big indicator of a risk for these other symptoms. And consistently in other literature, for example, with borderline personality disorder, we see nightmares as a strong link to suicidal thoughts and behaviors. So definitely an important area for why we should be assessing. Reintegration can also be challenging already, especially if you're not sleeping. So this can add additional stress with partners and children. Here we go. And especially the impact on bed sharing partners. So when I did my internship at the Minneapolis VA, I worked with folks there looking at partners of National Guard soldiers. So while those soldiers were deployed, we were assessing the partner's sleep during that deployment cycle. And what we found that there was a significant, so there was 4 different groups, but a significant group of partners showed significant increase in sleep difficulties while their soldier was away, potentially due to the stress or extra burden of care. And so when the soldier returned, as you can imagine, if now there's 2 bad sleepers in bed, that may exacerbate problems. And lastly, the last box here with substance use, soldiers and veterans report using alcohol or marijuana as examples to help them get to sleep. We see this at increased rates among our trauma-exposed groups. And so we know that these substances often work in the immediate, so they might help the individual get to sleep, but they definitely impact restorative sleep. And so individuals may be more likely to use these over time because it may not be working for actually helping them get good sleep, then they need to keep using it. And I wanted to highlight specifically with marijuana is that marijuana withdrawal, folks who they attempt a quit date, they see that their nightmares or strange dreams actually increase, and that's a symptom that doesn't seem to go away. And so that they're more likely then to go back to using marijuana in order to cope with that return of these strange dreams. And so this also speaks to the fact that while people are in substance use treatment, we also may be wanting to target their sleep as they're going through that. And I intentionally made this slide a little bit messy just to show that how many aspects of what comes through our door may be tied to sleep problems. All right, so now that we've talked about some of the common difficulties, I wanted to touch on the relationship between sleep and trauma exposure and what's sort of the current state of the literature. But as you can see from this slide, there's no consensus. And this is really because it's hard to collect information on traumatized individuals. So folks in the military, if they've gone out on a mission where a trauma occurred and they have to go back to base and maybe get ready for the next event if they didn't get injured, there might not be much time to process. With sexual assault or rape survivors, these folks tend to go underground, potentially not wanting to disclose, especially if it was an acquaintance or a family member. And so we might not hear from these people from long after the event has already occurred. And so it can be challenging to know exactly how sleep, when these experiences pop up. So we'll talk about this different ordering of how these things may be related. So it's sometimes easy for us to forget that those large numbers of folks who have insomnia before they even are trauma exposed. So in that previous slide, there are about 40% of our veterans have insomnia who may not have experienced trauma. And so many of our service members might already be going into combat or experiencing trauma with a history of poor sleep. Um, and so what the Gehrman group out of Philadelphia found that those soldiers who slept less than 6 hours before deployment and who subjectively reported insomnia symptoms were at significantly greater odds of developing PTSD compared to those folks who even slept 7 hours and didn't report insomnia symptoms. And so this highlights for us, and I don't have any role in policy change, but there may be the potential for pre-deployment screening to identify persons who may be at higher risk for post-deployment mental health disorders, particularly with PTSD. So if insomnia symptoms are a vulnerability to PTSD, then it may be an indicator that these folks may not do so well if they are exposed to these challenges or stressors, or may have more difficulty recovering once they return. I also wanted to highlight it's very difficult to really confirm that these rates are truly pre-trauma, as many of our service members come into the military with childhood adversity or previous trauma exposure. So one study found that 25% of our veterans had experienced at least 4 childhood traumas compared to 13% of civilian men. And so again, it's unclear exactly are these sleep problems that are before deployment truly pre-trauma or is it just pre-deployment? I think it's important here to touch on the role of military training and talking about how deployment can significantly impact sleep. So for example, in the latest combat zones, so folks were being deployed into deserts, into mountains. There was lots of construction going on. Folks may be working at nighttime because the temperatures were so hot. And so their cycles of sleep and daytime were swapped. Uh, Military members may also have frequent changes in their schedules for work. So some days working at night, during the day, they might learn to just sleep when they can based on these schedules. Additionally, a lot of traumatic events happen at nighttime, so missions may occur at night, sexual assaults may occur at night or in the bed. And so these can also be linked to some of those maintaining factors of fear of the dark or fear of sleep. And there might also be a cultural belief connected to not wanting to bring up sleep problems as a concern. So suck it up, sleep's a luxury, especially if there's not enough human power during missions. They need all hands on deck. So even if you are sleepy, you got to get going. And so this may be also something that lingers longer of sort of saying, well, there's nothing that can really be done with it. This is something that I'm going to live with. It's just how it is. And important points too with the OEF, OIF military folk is that they have repeated deployments. They may not have a lot of time home to readjust, to get back acclimated. And then a lot of bad sleep hygiene habits can occur while they're deployed. So, for example, something that we hear all the time or we see is that our veterans are drinking lots of Monster energy drinks, Red Bulls throughout the day, rock stars, as Dr. Jameson mentioned, um, which can significantly impact their sleep and their trying to come up with a regular routine. So I wanted to highlight those important points, and these may be significant factors for why there's such large insomnia rates, even without trauma exposure. And I wanted to point you all to this book, and it's also in the webinar resource handout, is the group out of Pittsburgh, so Wendy Troxel, has this really fantastic resource guide about how to promote healthy sleep habits in service members, highlighting policy changes that they would like to see, ways to assess, different treatment recommendations as well. So something to look for. All right, so we talked about the role of sleep problems prior to trauma, and what we also know is that sleep problems in the early aftermath of a traumatic event may also be linked to PTSD. But this is also an area where it's incredibly challenging to assess people immediately after a traumatic event. So most of the research that's been done in this area has been on animal models or is assessing people 1 or more months after a traumatic event, which doesn't get us exactly at what's happening the day of or the night after their traumatic experience. But if we think about things evolutionarily, it may be initially adaptive for people to have sleep problems due to the vulnerability that's present when we're asleep. Being asleep is one of the most vulnerable states that we can be in. And so insomnia may make sense to be sleeping with one eye open, protecting yourself. Nightmares may also be helpful reminders. Don't forget what happened to you. Stay alert. Don't let it happen to you again. And so this may be an attempt to try to make sense of the trauma to keep yourself safe. But if these things are indeed initially adaptive, and then hopefully you're assimilating and getting this into your fear network and your memory, long-term issues may come up if they're not resolved. So chronic nightmares, for example, may be a sign of failure in that process. So some studies have found that insomnia about 4 months after deployment are significantly predictive of PTSD symptoms 8 months or more after coming back from deployment. Similarly, in a civilian motor vehicle survivor population, we see insomnia symptoms 1 month after an accident, predicting PTSD diagnosis a year later. So this may potentially be due to disruption of the REM sleep, and likely due to an aroused brain. So there's more that's coming out about exactly what's going on neurobiologically that's causing these arousals and potentially impeding the natural process of reducing these symptoms over time. But really, it's unclear exactly when it's no longer adaptive to have these sleep problems and when it becomes an indicator of difficulty ahead. But these studies are suggesting to us that there may be an opportunity to help a survivor soon after a trauma, help them get back to a normal rhythm. It's interesting, though, new studies looking at analog traumas. So these are basically with animals traumatizing poor rats. Um, what they found is that restricting their sleep, so basically depriving them from sleep that immediately following the trauma, so the first night cycle for the rat, actually prevented their development of PTSD-like symptoms. And the speculation is that it may prevent them from consolidating the memory. But again, like I mentioned before, we haven't done this in humans. We often don't get in contact with people immediately after a traumatic event, and so it's unclear how this would play out in human situations. All right. So how things can develop and become a chronic issue is we like to use cycles a lot, I feel like in our field. Um, But the idea here is that if a traumatic event leads to nightmares or insomnia, we then might start a cycle that maintains this problem over time. So we might, because of these things, we might see more disruption in REM sleep. Sleep becomes, we may lose large chunks of sleep, so we're deprived. If we haven't had adequate sleep, we then may have more distress during the daytime, more arousal, at, trying to deal with some of those other PTSD symptoms. And then as night approaches, we have this anticipatory anxiety. Oh no, what's going to happen tonight? How's tonight going to be? Am I going to have a nightmare tonight? Which only increases our arousal, which then may lead us to use avoidance or maladaptive sleep habits. So maybe people just won't sleep at all. They'll stay up, vigorously clean to avoid sleep. They may use drugs or alcohol to try to fall asleep faster or to get rid of those thoughts. May drink another rock star to stay wide awake. A number of other techniques to try to avoid these difficulties. And then that is more likely to exacerbate or lead to more nightmares or insomnia. And we can see people get trapped in this cycle. And so a lot of the folks that we see in clinic are stuck in this. They want to do something about it, but they're not sure how, and it's really impacting many different areas of their life. Okay, are we having any questions? I just want to make sure we can pause for a second if there's any clarifications as we move along. Okay. All right. So the next area, I know that was a whirlwind of information, but I wanted to switch gears a little bit to talk more clinically about how we might assess and conceptualize these difficulties and then talk about treatment approaches. So this next slide of do you ask? I'm sure I'm talking to people who do ask about this, but I want to highlight here that oftentimes if individuals come in and they're not complaining directly about sleep, they may not ever get asked about it by their providers. So one study found that community providers only asked about 25% of the time, or 25% of those providers asked about sleep. And so if folks are coming in complaining about chronic pain, for example, that might be the only thing that practitioners focus on. And so they leave sleep aside, maybe coming up to it later of, oh, how's chronic pain impacting your sleep? But they may not give sleep the focus that it deserves. And so what can happen is that patients may have this learned helplessness. Well, I've had sleep problems for decades, nothing can be done about it, no one really cares. so they might not bring it up. And particularly around nightmares, there's sort of this idea that uh, no, there's no treatments for nightmares. It's sort of Freudian, or it's weird trying to interpret dreams, so people don't really want to bring it up, or people feel like they need to convince their doctor that this is an issue for them. And so we'll highlight here how a few questions can really go a long way. There's also a whole slew of free self-report measures that are available that we often use here in research, but clinically they're very helpful to track changes over time. And I've listed these also in that webinar resource and where you can access them. But these range from looking at insomnia symptoms to also identifying nightmares and the distress associated with them. There's a fear of sleep inventory, which is really helpful to get at, do people have fears of the dark or avoiding sleeping at nighttime, for example. And so I'll look at some of these here. I don't know how well this just shows up on your display, so I apologize if it's blurry, but I'm happy to send these measures to you. This is some of the questions from the trauma-related nightmare survey, which I helped to develop at the University of Tulsa with my advisor there, Dr. Javis. But this is a very helpful clinical tool because it starts the conversation going about nightmares. So it's asking, how fearful are you to go to sleep? It's asking about frequency of nightmares, how often are they happening, how disturbing are they, and then how much are they related to the event that you experienced. And then it goes on to assess what kind of things they do to deal with them. This is the top part of the insomnia severity index, looking at the specific symptoms of falling and staying asleep. Here are some questions from the dysfunctional beliefs and attitudes about sleep. And this can be really helpful to get a sense at what are some of the cognitions that folks have that are maybe maintaining their symptoms. So, for example, like I need 8 hours or else I can't function, or I'm worried about that I'm losing control about my sleep. To sort of see what are they thinking about that may not be so helpful. And this is the stop part of the stop bang, which assesses sleep apnea. And so these are some quick yes or no questions to get a brief idea of maybe these people should go on to get a formal evaluation. The one drawback of this particularly is if your patient does not share a bed with anyone, they may not know that they snore, or they may not know if they stop breathing at nighttime. So it may not be particularly helpful for everyone. This is so tiny, at least on my screen, but I wanted to highlight the importance of sleep logs. They can be very helpful for looking at patterns. And this is a more comprehensive one that we've used in nightmare treatment trials than the Universal Sleep Diary because it inquires about nightmares and bad dreams. So particularly for clinical settings, you could develop a sleep diary that best suits the population you see. So if you see a lot of people with sleep apnea, you could throw on a question about, are you wearing your CPAP or not? But at the top box highlights two areas. How much were they thinking about their nightmares before they went to bed, or how distressed were they? So that might look at that anticipatory anxiety. And the box at the bottom is asking, how many nightmares did you have? How upsetting were they? How many dreams? Were they positive dreams or negative dreams? And then looking at what may have they used before going to bed. So for this example, the person had Ambien and a beer. A lot of folks I see, they use marijuana, other alcohol, and so that can be also helpful to track over time. So important additional trauma-related questions that might be helpful. We touched on this already about fear of sleep or the dark, but asking people, do you prefer to sleep during the day? I see a lot of folks who like to nap. They feel safer, or they sleep with all their lights on or a TV on at all times. Checking your safety behaviors may be also important to monitor. Patrolling the house, sleeping with a weapon can be particularly important for safety concerns. And then again, what substances are they using? especially in the middle of the night. After a nightmare, are they smoking again? Are they drinking again? To get a sense at what may also be maintaining these difficulties. Briefly, to touch on objective measurement, this can be a helpful aid of getting a better sense of what's going on, but may not always be practical. But the polysomnography or PSG is the gold standard way of studying and evaluating sleep, and this is particularly helpful for diagnosing sleep apnea. And so if you are working with individuals who it may be a high likelihood that this is going on, a formal sleep study is highly recommended. Actigraphy is basically worn like a watch, and it measures activity through accelerometers, and it's a useful tool to start looking at patterns for disruptions of sleep, wakefulness during the night. It's less expensive than polysomnography, and people can wear it over time. And this is a really quickly developing field. So I have this image there of the mattress. So it's a shout out to Dr. Woodward, our boss, but he's looking at, and I'm helping him, looking at validating his mattress actigraph, being able to measure movement while people are just laying on their mattress. But there are a few caveats. So I have a picture of a Fitbit there, and actigraphs, for example. If an individual is not moving in bed, so if they're just laying there, that tired but wired image, kind of laying there, but their mind's going wild, these devices may assume the individual is asleep when really they're not. And so that can be a challenge to really getting an accurate picture. Additionally, these devices may encourage individuals to place more value on a poor night's sleep. So I'm an avid Fitbit user, and if I get less than my ideal rate, or it shows I've been awake for a little bit during the night, if people start saying, well, I'm not getting good sleep, I might have insomnia, they might then, unbeknownst to them, start worsening their sleep. And so we really want to be mindful of that, especially if folks coming in for treatment are wanting to use these tools. Additional factors to consider when conceptualizing sleep. There are important, so this was an area we weren't sure exactly where this fit in, but we wanted to make sure we acknowledge that we're missing important variables as we talk about this. There's a lot of factors that go into sleep, and we acknowledge that, and so these are a few. So there's important sex differences that are out there about sleep. So women in general are at increased risk of developing insomnia, and this risk really starts at the time of menses. And so that's highlighting to us that this is a biological factor. And as I have later on here, the hormonal impact. So we see changes in sleep even during the ovulation cycle, menstruation, and then once women hit menopause, we see higher rates of insomnia even there due to potential for other physiological factors like hot flashes, for example. And particularly among military women, those who have insomnia are more likely to have other mental health comorbidities as well as physical medical comorbidities. There's also important age or cohort differences. So we know in general, as people age, their sleep tends to worsen. So having more awakening, shorter total sleep time. So this is important for our aging military and veteran populations. And in contrast, the newer cohorts may be impacted by different things. So blast injuries, TBIs, for example, may mediate the relationship. These sleep problems may mediate how well they're recovering or their psychological outcomes. And this is also linked to more complaints of fatigue. We know the role of chronic pain can lead to less activity, which then may impact sleep as well. And lastly, touching on environmental safety, and I think this is important with our veteran population, is that we see about 6% of veterans who've been within a year have been referred to mental health specialty clinic are newly homeless. And we know for folks that are homeless, their sleep isn't so good. So they sleep a significantly shorter amount of time, more fatigue, they might be using more sleep aids. And we also know that individuals who just don't feel safe where they're living are less likely to sleep very well. And so it's important to also ask, about people's neighborhoods. Okay, so I'm aware of the time. I'm gonna speed through the treatment, which I know is an important area, but it's a caveat that I'm not going to be talking about how you go about treating these issues, but we are very happy to direct you to those resources. So it's more about what treatments are available. I wanted to direct you to the VA and DoD guidelines if you haven't already checked them out. This group came out with a new clinical practice guideline for PTSD in June. I have a link to that as well, I believe, in the webinar resource, but I'm happy to share that as well. But as you can see from this first sentence, they are not happy with things. So basically saying there's a low confidence in the sleep literature on sleep disturbances with PTSD. And this is primarily due to low sample sizes, few trials that are comparing active treatments, few trials with military or veteran populations in general. But I highlighted here the positive is that they really say, the risk of treating sleep is low, and it may be really important for buy-in for your patients. So if you can get their sleep better, uh, they may want to engage in other treatment as well. And so it's something that doesn't cost a lot, but may have greater long-term impact. So the only treatment that they recommend is cognitive behavioral therapy for insomnia, or CBTI. So it's the only recommended treatment. I'm going to skip this part here, but it's basically a multimodal therapy approach for insomnia. But the two key areas are stimulus control and sleep restriction. So stimulus control is basically making sure that when they're sleeping, when they're in bed, they're sleeping, and when they're not, they're out of bed. And sleep restriction is really honing in on how much time are they in bed not sleeping, and to shorten that. So for example, if an individual is really a 7-hour sleeper, they should only be in at bed 7 hours. And initially it might be less than that to build up their drive for sleep to consolidate it. So this treatment is considered a first-line treatment for insomnia. It has much larger effects and greater improvement over time compared to medications, and it leads to clinically meaningful changes. So people are able to fall asleep faster, they don't wake up as much in the middle of the night, and they even perceive their sleep more subjectively improved. If you are in the VA system or the DoD system, there are clinical rollouts for this that clinicians can go through, and there's also online trainings found at the deploymentpsych.org. I'm happy to send those links as well. Short plug to CBTI Coach. This is an app in development with the National Center for PTSD here in Menlo Park. And so this is an app that is used in conjunction with clinician-supported CBTI, and it has lots of resources. So people are able to complete their sleep diaries on this. They have options for mindfulness techniques, etc. And a small pilot study showed that it doesn't negatively impact treatment, so it actually may increase treatment adherence. I know I'm flying through this and trying to be mindful of the time. I wanted to touch briefly on cognitive behavioral therapies for nightmares. So unfortunately at this time, these treatments are not recommended by the VA or DoD guidelines, and that's really because there's only been few trials done in veteran populations. But the one that most people probably know of is called imagery rehearsal therapy, or IRT. Basically, an individual selects a nightmare. They don't necessarily expose themselves to the content, but they re-script it or change that nightmare in a new way to make it less negative. Another treatment that I have more experience with is exposure, relaxation, and rescripting therapy, or we call it ERT. And this is where the individual selects their worst, kind of the big bad nightmare that they have, and they expose themselves to it through a written or an oral exposure process. And then they rescript the nightmare using trauma-related themes. So if there's powerlessness or safety or control, they might change it to feel more in control or less out of control or less powerless. And then there's also additional strategies for relaxation, modifying sleep behaviors. So like I mentioned, these treatments are not currently recommended. However, there are civilian studies showing that they are efficacious. So the Cook study is the one that was done in the military that showed some reductions, but not complete reductions in nightmares compared to the control group. And then the ERT for military, this was a pilot study, so it was an uncontrolled study, but found significant improvements in reduction of nightmares, as well as PTSD and depression symptoms in the veterans. Okay, we've got a few more slides here, and then I'll wrap up. Treatment for OSA is CPAP. And what they found is that treating sleep apnea with CPAP is associated with decreases in nightmares and other PTSD symptoms. But the caveat is those who did better wore their CPAP more, and which makes sense. But those who have PTSD are less likely to adhere to their CPAP. So it's sort of this catch-22, I guess, where you need to wear it, but this diagnosis may impede people from wearing it. And the potential may be that the mask, people complain about feeling claustrophobic. It may be a threat cue, especially if they had to wear masks like that while they were in war, so they may not want to wear it. And so there's different strategies. New studies are coming out actively, even here at the VA Palo Alto, looking at what are other ways we can get folks to wear these. And so potentially motivational enhancement, getting people to wear it during the daytime hours while they're watching TV to get acclimated. There's different strategies that are being employed and investigated. And briefly to touch on psychopharmacology, we are not prescribing psychiatrists, so that's a caveat here. We're clinical psychologists. But again, no recommended medications for sleep problems according to the VA and DoD guidelines, and totally recommend against benzos. So many of you have probably heard of prazosin, which is often used for treating nightmares, but there's differing conclusions about its benefit. So in civilian studies and some military as well, it's found to be helpful in treating PTSD and nightmare symptoms, but in a large multi-site VA study, it was not shown any more helpful than a placebo. So more work is definitely going to be underway for that. Additionally, with SSRIs, there's some evidence for its utility, but no rigorous trials have been conducted. Okay, I'm probably going to end on this slide here, just focusing on PTSD treatments and how do they help sleep. So some folks benefit from PTSD-focused treatments alone. They report reductions in sleep disturbances, but insomnia in particularly often remains clinically significant as an issue. So even if they are able to function well, avoidance is down, other things are down, sleep problem is still a big concern for folks. And so there's studies going on in multiple sites around the country, both in military and non-military samples, looking at the ordering of things. So if we get people sleeping better, will they benefit more from PTSD treatment? Or is it that we should treat PTSD first, and then if they have sleep problems lingering, we should address those second? And so these studies are being examined both within insomnia as well as nightmare symptom groups. Okay, I'm going to skip the next slide and just go to see, did we meet our conclusions? I hope so, or our objectives. But in conclusion, so we've talked about some of the frequent sleep problems that occur, particularly with nightmares and insomnia. We've talked a little bit about this relationship about how sleep beforehand or following trauma may be linked to PTSD increases. We've talked about ways to assess these problems and then briefly discuss some of the interventions that might be available. So thank you all so much for listening and happy to provide a discussion, answer any questions, or direct you to any materials that might be of interest. Yeah. And here's our contact information as well.
Thank you so much, Dr. Miller and Dr. Jameson. We'll be answering questions now. So if you have any questions related to the topic that was presented today or in general about sleep disturbances in veteran or military population, you're welcome to write in the chat box, and Dr. Miller and Dr. Jameson will address your questions. Wait.
Thank you all so much. So I see there's a question about the availability, about if the slides are available. So we have a PDF version of most of the slides in the files box and the presentation handout. I left out some of them that were more just the filler slides, but happy to share additional ones if you have those questions.
Just great.
And it sounds like everyone else is just praising us, so I appreciate that. Thank you so much. If there's no other questions, happy to answer anything offline again. Really grateful again for the opportunity. I hope you all sleep well tonight. Sleep tight. Hi, Antonia. This is Catherine. I can't see the text box very clearly, so I'm just going to start talking, but please keep typing. I think you're typing still, but they'll let me know what you are saying. But in terms of the REM behavior disorder, folks are sleeping through these acting out. So it's particularly during REM that they are thrashing around or acting out their dreams. But if you're also interested in the objective sleep parameters about sleep, we do know that individuals with PTSD tend to have more disturbances to their REM. So it's more fragmented, so they may not have as much or they go in and out of REM more often. But interestingly, there's what's called REM density, which is the frequency of how much their eye movements go back and forth, basically. And we see higher densities in folks with PTSD. And the potential is that there might be more pressure to get into REM because they're so deprived of sleep. So that's why we might see trauma nightmares occurring even earlier in the night because these people are deprived, they go straight into REM, they have these nightmares, and then they might not get the rest or more restorative REM sleep later on in the night. So I don't know if that answers your question. Let me see. I'm going to go back.
Read it.
I'm going to look at, okay, so I think in REM, I don't think that the amount change in the REM behavior disorder. I don't know that the REM actually
Let me know
changes in
since I can
quantity.
speak to you right now.
Okay, if you have a microphone, you can speak to me. If not, feel free to type.
Does anybody have their volume on their computer?
Hi, can you hear me?
I can, yes, sorry.
Awesome, okay. No, I think that pretty much answered my question. When you talked about sleep density, that was actually really, the REM density, that was actually really interesting. I didn't even think about that. So that's what's really interesting to find out. But yeah, I was asking about kind of the quality of the REM sleep, especially since it sounds like people with PTSD tend not to get as much sleep as they need because of the nightmares and insomnia.
Yeah, definitely. I think the area of REM is an evolving field. So especially when I was talking about the polysomnography or the lab studies, there's every study group seems to find differing results, and that's why at least with the REM density, that's something that has the largest effect in meta-analyses. So it seems to be something that's popping up more often. But some folks think of individuals with PTSD have more REM, some more that it's more fragmented. So again, it's something that's still evolving. But if that's an area of interest, the Tom Mellman and Kobayashi are folks that are exploring that, and they have the meta-analyses out about the REM density piece.
Oh, awesome. Yeah, I'll look that up. That's really interesting. Thank you.
Yeah, you're welcome. Thank you so much for your
No
questions.
problem. Thank you. It was a very informative lecture. I really enjoyed it.
I'm glad. Thanks so much.
All right.
Have a nice
You
night.
too.